Good afternoon, everyone, and welcome to this afternoon's WorkSafe Tasmania Month webinar, WHS Challenges in Workers Returning the Ageing Worker to Vocational Duties. I'm Stephanie from WorkSafe Tasmania and also the coordinator of WorkSafe Tasmania Month. I'll also be your moderator for this afternoon's webinar. Before we get started though, I'd appreciate you taking a few moments to read the following slide about information delivered during WorkSafe Month sessions. I'd now like to go over a few items so you know how you can participate or interact in today's webinar. So we've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your computer screen in the upper right corner. You're likely listening in using your computer speaker system by default. However, if you'd prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You will also have the opportunity to submit text questions to today's presenter by typing them into the questions pane of the control panel. You can send your questions in at any time during the presentation. We will collect these and address them at the end of today's presentation. We are also recording webinars during WorkSafe Tasmania Month and will progressively make those webinars available after WorkSafe Month finishes on the 30th of October on the WorkSafe Tasmania website. And lastly, today, before you do leave, you will receive a survey on the presentation and we would appreciate you taking a few moments to complete that survey and providing us with your feedback about the presentation and also about your webinar experience. So, it is now my pleasure to hand you over to this afternoon's presenter from Physiotherapy and Industrial Solutions, Kim Stoys. Welcome, Kim.
Thank you, Stephanie, and good afternoon, everybody out there. I don't think my buttons are working. Just 1 minute. Here we go. So today I'm presenting how to help ageing workers return to their vocational duties. Just a little about myself. I'm a physiotherapist of 31 years. Spent a lot of time in public teaching hospitals in Sydney, moved to Tasmania in 1996 and became involved in rehabilitation of workers and was trained with functional capacity evaluation tools which have expanded my business practice understanding of the challenges that face all workers. So I'll be talking a little bit about functional capacity evaluation and how you can use those tools to assist workers back to their vocational duties. Well, since the global financial downturn in 2012, there's been an economic shift with most companies facing less income for solving issues concerning health and safety, business productivity and sustainability. Government directives are pushing towards an older workforce as the cohort of baby boomers become eligible for retirement, leaving a smaller tax base for potential retirees. According to Safe Work Australia, the proportion of older workers aged over 65 will rise from the present 12% to 18% in 2051. From my experience as a physiotherapist in the area of occupational health and safety and functional capacity evaluation of workers in the last 15 years, there's a growing trend for workplaces to protect themselves from the unwanted cost of injury or harm to their workers. After all, Safe Work Australia states that employers have a legislative responsibility to ensure that all reasonable steps are taken to protect the occupational health and safety of their workers. So, what are the implications of an older workforce? The interaction between age, work and occupational health is not well understood. Ageing results in mental and physical changes, but there's a large variation between individuals. Given this and the fact that ageing workers tend to develop a wide range of coping strategies, it's hard to predict the exact relationship between age and occupational safety. Older workers need high reserves for energy, and as physical capacity declines with age, the heaviness of the worker's vocation contributes significantly to their ability to continue to produce at an acceptable rate. This situation, together with an increasing potential for chronic disease, decreases the safety margin which protects the worker against injury and work-related disease. If older workers are to be treated fairly and given due care by the workplace, it's important that consideration is given to the decreased physical capacity of the worker, and it is important that modification of tasks is considered so that physical demand is consistent with reduced physical capacity. These changes should be made on the basis of a discussion with an ageing worker and an assessment of their physical demand and postural tolerances. Functional capacity evaluation is a specialised aspect of assessment that is carried out in general by physiotherapists and occupational therapists. There are several different protocols in use. Oh, I'm sorry, I'll just go back one. Oh, I think I must have hit two. I beg your pardon, audience. Functional capacity evaluation is a specialised aspect of assessment, and there are several different protocols in use in Australia. The professions assessing workers have an understanding of anatomy and pathology with physiological knowledge of systemic disease. More importantly, however, therapists have studied movement patterns. The best assessors have a long history of clinical assessment and treatment of clients and can use clinical reasoning when asked, does function equate with the pathology shown? An FCE is a battery of testing procedures that attempts to identify a worker's physical demand and postural tolerances. There may be many reasons for employing an FCE, including injury prevention, work-related injury or illness management. In context of treatment, when the client may not have reached maximum medical improvement, or when a client has reached maximum medical improvement with chronic illness or injury management, or when case resolution needs to be made. Baseline FCE components must have the following. This is according to Genovese and Galper 2009. They must have an informed consent, evaluee interview, musculoskeletal examination, evaluation of movement and postural tolerance, assessment of evaluee effort, dynamic tasks, aerobic capacity, and all those things can be rolled in to give an outcome for her rehabilitation program once the FCE has been completed. I'd like to introduce you to 3 case studies. Oops, again, sorry, the computer's just gone a little bit wild. Introduction to 3 case studies that I'm presenting, and they're sourced from testing I've performed upon workers who have come to the attention of their workplace being flagged as potential risk for that workplace. That is, they're not normally requested by an employer when, they are normally requested by an employer when there is a perceived threat of harm to a worker while performing in their vocational role, or a perceived threat with regard to lost productivity. This situation is necessarily distressing for both employer and employee, as both stakeholders must face the potential that after testing the worker may be deemed unfit to continue in their present role. For the worker, there's a real threat perceived that they're about to lose their vocation in what seems to be an ever-shrinking employment market. For the employer, there is the difficulty of finding a suitable alternative role for that worker if they are found to be unable to continue gainfully in their present role, and if not, the possibility that they will need to let that worker go. Often there has been a long history of loyalty between worker and employer, and it's fair to say that both parties feel distressed at the prospect that the worker will be found lacking in functional ability. Today I'll present 3 case studies where I've been asked to assess the ability of a worker to continue to meet their vocational demands and some of the outcomes that I've been part to as a result of such testing. To show before and after results in improvement in 2 of the case studies, I've used data that has been gathered by static strength testing, as it's easily understood by employers and employees. And that's the slide that you have on your screen at the moment. The slide on the screen is a static strength test that to assess the ability of a person to generate force against an immovable object. Static strength testing was first used in the development of the United States NIOSH Work Practices Guide in 1981. And the same data has been used to assist in the development of the Dictionary of Occupational Titles in 1991, which helps to classify the physical demand of almost all jobs. This slide shows the force curve generated by a person exerting static force for 5 seconds in 3 different postures. The force curves shown here overlap each other and can be considered evidence of sincere effort. The strength of the force curve can be matched with a database of similar matched industrial norms. There are 8 standard static strength postures which stress different joint complexes, so joints can be compared to each other for strength and weaknesses. This is the first case study. This is one of Kieran. Kieran's a 54-year-old labourer with a heavy physical demand, so his work's quite demanding in a physical way. He's worked heavily all his life and he was noticed experiencing pain with excavator driving and other heavy vehicles. His supervisor noticed Kieran to be in pain at the end of the day while working on a particularly heavy project and over rough terrain. He had had several exacerbations of lumbar pain but no workers' compensation claim. He had a few days off, and over the last month while working on the last project, due to ongoing back and some leg pain, he appeared to recover with rest, but the supervisor was concerned about Kieran's appearance at the end of a 12-hour shift. I was requested to assess Kieran for suitability to work demands and whether the present duties were too difficult. Productivity had not been an issue, rather one of occupational health and worker safety on site. I interviewed Kieran. Kieran acknowledged that he had been struggling of late with the heavier demands of his job, especially shovelling and material handling. He felt tired and in pain at the end of the shift, especially after prolonged shovelling. He was waking in the morning with stiffness in the lower back that took some time to relieve, and he also had occasional episodes of sciatic pain in the left posterior thigh. He felt concerned about his viability as a labourer into the future and admitted to thinking about possible other employment that was of a lighter physical demand. He had had medical imaging showing severe arthritic changes throughout the lumbar spine and several small disc bulges. It should be noted that such changes are common in similar age-matched norms. I performed a musculoskeletal assessment as part of the FCA, and I noted Kieran had limited ability to bend the spine, tight muscles in the lower limb and pelvis, and weak abdominal muscles, which are critical in supporting the spine. He also had a poor understanding of his problem and no understanding of how to manage his problems. Oh, sorry people, the computer is just going a little bit fast for me. Okay, this slide here is showing Kieran's static strength test, which I performed on the 10th of the 2nd of this year. The test postures are shown in this table and the results in kilograms can be seen for each posture, and the comparison with the NIOSH norms strength percentile, which is on the right, of the very right column. Kieran's average static strength percentile was in the 30th percentile as compared to similarly age-matched norms. Take note, however, that his back lift is in the 1st percentile. This indicates that he has a problem with the strength about his lower back. In fact, when a calculation is applied to his average strength and his lumbar spine, there is a significant deficit about his spine of 77%. Kieran was given a plan to address his issues. I decided to educate Kieran about the nature of his spinal pathology. teach self-mobilising exercises for his arthritic joints, exercises for stretching restricted lower limb muscles, strengthen his core stabilisers, which are the abdominals, and teach Kieran the importance of maintaining his own physical fitness for work, including an ongoing home exercise program. So Kieran underwent 4 weeks of 3 times weekly attendance at physio. He also had a home program, of course. Initially, I assisted in stretching and mobilisation of his spine, and then he went on to 10 sessions of gym strength training focused on abdominal stability, and then progressing to abdominal stability with activity. Kieran was compliant and conscientious, and Kieran was then retested after his rehabilitation. This is the slide that shows Kieran's static strength test after his rehabilitation program. His average static strength is now in the 52nd percentile, so that's a huge increase in strength. And note, in the back lift, he's now at the 35th percentile for strength about his spine. Kieran was feeling much better. He had more spinal mobility, less morning lumbar stiffness. He still has pain in his lumbar spine with prolonged flexion activities. And I communicated this with the workplace manager regarding the results. The manager wanted to know the risk of harming continuing heavy physical demand. Due to the significant nature of arthritic change and the risk to Kieran continuing his role as labourer, I considered it still high. A decision was made in conjunction with Kieran to discuss an alternative role within the company involving a lower physical demand, and this was successfully made. Case study 2 is Eric, aged 54. He's a forklift operator at a busy depot and has been for 15 years. He has infrequent material handling. He does walk over rough terrain and about objects stacked in the depot. Forklift driving has a medium physical demand according to the Dictionary of Occupational Titles. The supervisor was concerned that Eric has a noticeable limp and concerned that he may injure himself while climbing in and out of the forklift and negotiating obstacles in the depot. He's not required to squat, climb ladders or stairs. Eric knows that he has been diagnosed with osteoarthritis in multiple joints, but his left knee is particularly affected. He recently had an episode of knee swelling which made his limp more pronounced, and he was asked to be seen by the company's GP. The outcome of the assessment was that the company's GP has certified Eric as being suited to modified duties only and for several months, and he won't clear Eric unless a formal assessment is performed. Eric is concerned that the company wants to cease his employment due to his arthritis. Eric's very concerned about his financial state if his employment is to be terminated. He has no other work skills other than manual labouring or forklift driving. Eric manages his job and has not taken time off for his pathology. He manages his pain with prescription and over-the-counter medication, none of which interfere with his workability or safety. He feels he has no problem with fulfilling his vocational duties and is as productive, if not more so, than his younger counterparts. He understands that his left knee range is restricted and he has a degree of pain associated with this, but he feels he's managing well. An FCE was performed. In the FCE, the musculoskeletal examination showed that the demonstrated ranges of motion of his left hip and ankle were all within normal amplitude for age, but the right knee range of motion was restricted to 90 degrees of bending. The musculoskeletal assessment was compatible with the expected severe osteoarthritic changes. There was no evidence of swelling about the left knee. He was unable to squat past half the usual depth of a full squat due to his left knee restriction. Strength testing for the major joint complexes of the pelvis and lower limbs revealed good strength bilaterally in all muscle groups tested. His muscle length about his lower limbs was restricted, which did not help Eric's arthritic condition. Eric was assessed via mini functional capacity evaluation, and video footage of Eric performing activities while performing his activities, we videoed Eric doing duties consistent with vocational duties as attached to his DOB statement and evaluation. After assessing Eric with his mini FCE, it was found that he was able to perform all the duties associated with his statement of duties provided by his employer. His physical demand was medium heavy, higher than his vocational demand, so he was coping quite well. Video footage of him carrying weight, 22.2 kilos, about obstacles, climbing in and out of a mock forklift, climbing up a ladder, balancing, etc., accompanied the report. I gave Eric a series of stretches for his lower limbs to help him cope a little bit more with his restricted knee problems. An associated video was presented to his company's GP, who then cleared him for normal duties as per his statement of duties. His report. The last study is that of Tom. Tom's a 50-year-old batch plant supervisor, and he has been for 10 years. He's had several episodes of lumbar spine pain. He's taken several days off over the last 2 years due to back pain exacerbations. Again, there's no history of workers' compensation. Tom's GP, however, has certified him fit for modified duties only and indicates that he should not drive the loader at work. Management's concerned that the GP will not clear Tom, and Tom has been on modified duties now for 6 months. Tom's said that a recent MRI shows that he has arthritic changes in the lumbar spine and several disc bulges. Management have asked me to assess Tom's workplace, perform an FCE and make suggestions as to how to manage this situation. Tom's job requires medium physical demand with normal postural tolerances such as bending, squatting and climbing. There is some apprehension between work and Tom. Tom's not really keen to return to work on normal duties. Tom expects to be kept on modified duties as he feels that his work has contributed to his condition. Tom does not see it his responsibility as a worker to manage his back issue. He's not had any physical intervention. I perform a workplace assessment. Tom's workplace as assessed, has really no recommendations for Tom's comfort being required. I recommend assessment of Tom's condition and a self-management strategy be implemented. I perform an FCE. In the FCE, Tom has stiff ranges of motion throughout most planes in his lumbar spine. He has tight hip, lower limb and pelvic muscles on the left. He has very poor core strength, which are the abdominals. He has no knowledge of the nature of his problem or how to manage back pain exacerbations. I propose a 4-week times 3 sessions a week involving education, stretching, mobilisation of the spine into extension and core stability exercises. I give Tom education about his condition and encourage him to take responsibility for his health as a worker and as an individual with a life outside work. This slide shows the static strength testing that I performed on Tom before he actually started his program. There's no functional strength deficit for his spine, even though it's only in the first percentile. His average strength percentile, however, is only 13%, and that's considered poor. Note that his back lift is in the first percentile, so there probably is a problem with his back. This slide shows the results of the repeat static strength testing after his rehabilitation period. Note now that his back lift is in the 71st percentile, a massive improvement. His average strength percentile is 48. Although hesitant to comply at first, Tom was surprised at his strength had improved to such a degree. He then went on to tell me that his morning pain had settled considerably, his lifestyle had improved, and he could get his socks on in the morning. I stressed that these changes would only continue with his commitment to his own personal health and continuing his regime of exercises. Tom went on to be cleared by the GP and returned to normal duties after presenting the data to his doctor. So, in summary, assessment of workers through functional capacity evaluation can identify areas where a worker may be able to improve their functional ability through correct strategies, including improvement in musculoskeletal function and education. After testing, dialogue between worker and employer may be implemented that assists the employee to regain full employment potential through use of education and physical training, and allow the employer to feel happy regarding the state of their employee. I found satisfaction in showing employers that a flagged worker with chronic disease such as osteoarthritis can work quite well despite their perceived impairment and with the appropriate intervention. I've also found great satisfaction in knowing that an employee who clearly is struggling to maintain their productivity has undergone testing which clearly shows that the physical demand under which they are working is too great, and their vocation has, as a result, been altered to suit their changing physical status. Even if an employee is found to be unable to sustain their particular employment, by engaging the worker and employer in sensitive discussion regarding future vocational directives, there is a sense of fulfilment that the worker will not be exposed to harm, and when dialogue is open, the worker can go on to a less demanding job, which allows greater enjoyment in all aspects of life. And that concludes my talk for today about getting ageing workers back to work. Thank you, Stephanie.
Thank you very much, Kim. And as you said, thank you for showing us how workers with age-related degenerative changes can be rehabilitated back to work with assistance of corrective intervention by physiotherapy. So we do still have some time if anyone would like to submit any questions to Kim in regards to her presentation this afternoon. While any questions are coming through, I'll just remind everyone again that obviously WorkSafe month does run until the 30th of October. We are running webinars again tomorrow at 10 and 2 p.m. and the program is basically along those lines in regards to the webinars. We do have live feeds again continuing next week, so do have a look at the program which is on the WorkSafe Tasmania website, or do have a look at the WorkSafe month calendar and directly register for any of the events that are coming up over the next few weeks. And as I mentioned, we are recording the webinars, so if you do want to go back and watch any of the sessions that that either you watched and want to watch again or didn't get a chance to see, then do have a look out for those webinars, which will progressively make their way to the WorkSafe Tasmania website at the end of the month. And again, lastly, before you do leave today, please do stay online, have a look at and give us your feedback about this afternoon's presentation and also about your webinar experience. So there's still a few moments to submit any questions if you do have them. One question I guess I probably do have, Kim, I guess I noted with the case studies that you presented, the workers that um, that you showed were obviously working in heavy sort of labour intensive situations. Have you sort of dealt with workers who I guess have needed to or had degenerative changes due to I guess less heavy work?
Yes, certainly sedentary workers are just as exposed to changes within their bodies as people who work in heavy situations. Probably less joints take stress in a more sedentary workload, work environment, but certainly people who work behind a desk or who have light physical demand. We're all human beings. We all degenerate in our joints as we get older, and it's the American College of Occupational and Environmental Medicine says that getting older and degenerative changes are it's very normal, and we need to realise that we're all going to degenerate. Shoulders are a thing that certainly are exposed to change with sedentary workers, people who work behind computers, and the same process applies. You assess the person, find out where the weaknesses are, and give them a program to actually address those areas that are weak or the loss of range in perhaps a shoulder. You might change the way they sit or their desk or their chair, but basically, we all need to maintain our strength and flexibility as we age because it is a fact of life that we do wear out. So it's not just confined to the worker in the heavy industries, but certainly I've done a lot of work with people in sedentary, light, medium demand jobs such as secretarial work, people who are driving vans. It's more about the postures that we adopt and the repetitive movements that we use to perform our work. So basically we're all going to wear out. We just need to understand how our bodies work, and that's where the intervention of someone who is a clinician can help to make work and life more satisfying for people by showing them strategies to overcome the changes that happen with our bodies as we age. It's not all bad news.
and I guess because we are I guess becoming an ageing workforce, and do, would you therefore say that we shouldn't be waiting until conditions become degenerative and therefore we seek out physio? Should we be looking at ways to reduce these issues now by looking at the way we work?
Oh, it'd be lovely if we were all proactive, but unfortunately from what I've found most human beings are actually reactive and tend not to be proactive. Often it's an incident at work that draws attention to a weakening area, perhaps in actual fact, it's usually what we've done in our 20s and 30s and our youth that can impact upon our workability as we age. And often people don't even realise that a joint is becoming stressed or muscles are becoming shorter as they work until an incident happens. It'd be great if people paid more attention to stretching and we pushed more stretching and pause breaks and rest breaks and get up from the computer. And it's really good that people are now starting to stand at workstations, but unfortunately people tend, as I said, to be reactive, and it's only when we see or perhaps a drop-off in their production that they're pointed towards getting some advice. But that's where you get the advice, is from a good clinician, and certainly there haven't been many people who I have found that haven't been able to be helped return to their normal activities of work, vocational work and activities of daily living.
Okay. Thank you for that, Kim. As I guess no further questions have come through, if anyone does want any further information from you, Kim, they're more than welcome, obviously, to contact you.
Yes.
Yes.
Would you like my email address?
Yes, if you
Okay.
would. Yes.
It's K. Okay.
Yes.
KATSTOJS@bigpond.com is my email address, and I'm certainly happy to answer any questions with regard to anything I've spoken about today.
All right. Thank you very much, Kim. And thank you also to everyone for attending this afternoon's webinar. Again, if you do have any questions, please do feel free to contact Kim or seek advice from other sources. But as I said, once you do leave today's webinar, you will receive a survey on the presentation, and we'd appreciate you completing that feedback. So thank you very much, Kim. And on behalf
And thank you, Stephanie.
of WorkSafe Tasmania, we hope that you have a good rest of the day, and we hope that it's a safe and healthy one too.